This talk really, I guess, should be called anticoagulation or no anticoagulation for patients. The story for anticoagulation is sort of similar to the story for heart failure, right? Over the 20 years that I've been in cardiology, we've done, or 25 years, we've done, you'll see in the data, a moderately good job of improving the rates of anticoagulation in our patients who are at risk for stroke. These are my disclosures. It turns out the most rewarding thing to do in medicine is to teach other people about medicine. And so a lot of what we do in our time is teach other people. So today we'll talk about some basics about atrial fibrillation and stroke, the standard of care for stroke prevention in the United States, and then non-medical prevention for atrial fibrillation, for stroke related to atrial fibrillation. It's possible that we're entering a period where we may look back on blood thinners as a sort of weird side journey that was a dead end in medicine. And so we'll talk a little bit about the evidence of that. And then there's some changes in the guidelines and some practical barriers to anticoagulation that we need to talk about and what's happening in the future. There are new medicines coming and new procedures coming. So the biggest changes in atrial fibrillation management are around anticoagulation. Pacing and AV node ablation for rate control is evolving. And this week in Albuquerque, we joined the rest of the United States in applying new ablation energies to fix atrial fibrillation. We did the first pulse field cases at the Heart Hospital this week. And I do think that's going to be very helpful for patients. And then, of course, left atrial appendage closure devices. There's widespread application of one device, and there are other devices coming to the market pretty fast. And so we'll talk a little bit about that. So it's important that we know what we're talking about when we talk about atrial fibrillation. There are a few different kinds of atrial fibrillation. I think when you have somebody who has a first episode of atrial fibrillation, it's important to recognize that you don't know what path they're going to be on. And so I think keep an open mind in that situation. And when people call me and ask me if we should anticoagulate the 50-year-old who comes in with atrial fibrillation, I often say, yeah, because you actually just met them. You don't know what their actual risk of stroke is until we've done a lot of other diagnostic testing. And so in this situation, our obligation to the patient is to be careful. And there have been a number of cases in my career where we've seen people who had strokes after they were already identified as having atrial fibrillation. Secondary atrial fibrillation is something that the hospitalized patient experiences, or the patient who's been exposed to steroids in a multitude of settings experiences. And these patients, again, we don't know what's going to happen to them if they're going to join the group of patients who have repetitive episodes of atrial fibrillation, or if this is a one-off related to their illness. So we tend to treat those patients as though they're going to be in the group of patients who have atrial fibrillation for the long haul. But you have to be aware that some of those patients will have long remissions in their life and may never have atrial fibrillation again. And so just that gives some of those patients some hope. And then paroxysmal atrial fibrillation. This is a group of patients who has atrial fibrillation that comes and goes on its own within 7 days. And again, this is a continuum between paroxysmal and persistent atrial fibrillation. I get asked by providers, coders, nurses, and medical assistants all the time, is it paroxysmal or persistent? And the answer is it's a continuum. And if it lasts more than 7 days arbitrarily, we call it persistent atrial fibrillation. There's a lot of evidence now accumulated that there's really no such thing as permanent atrial fibrillation. And I can describe a number of cases where somebody was in atrial fibrillation for a decade and then had an intervention and the atrial fibrillation was gone. And so the answer is, when somebody is described as having permanent atrial fibrillation, I would just ask that you ask the question, has sinus rhythm ever been attempted in the patient? Our model for atrial fibrillation, I think, is stabilizing, which is good news for all of you, because that means that you don't have to learn any new models. I think all of us now think that the trigger type atrial fibrillation is the initiating event for paroxysmal atrial fibrillation. And then patients, as they sustain an atrial fibrillation for more than a minute or two, start to enter this phase where they have rotor drivers and flutter rhythms that keep the atrial fibrillation going. And elimination of the trigger stops the initiation of paroxysmal atrial fibrillation, but somebody has to do something about the rotor drivers to fix and the flutter rhythms to fix the rest of the atrial fibrillation. And I think, again, this is finally stabilizing in a state where we can talk about it in bigger groups than just in electrophysiology circles. It's worth remembering that lone atrial fibrillation is a very rare condition. The chances of me bumping into lone atrial fibrillation are similar to the chances of me bumping into an elephant in Albuquerque, right? So the Mayo Clinic looked at their entire series of patients since 1970, and were only able to find 10 patients who they couldn't find another cause of atrial fibrillation in their healthcare in the follow-up to the initial presentation with atrial fibrillation. So it's really important to look hard for sleep apnea. I think the recent data suggests that 70% of American males at the age of 70 have sleep apnea. And so that means that a lot of people have sleep apnea before that. So paroxysmal atrial fibrillation, the sicker you are, the faster your atrial fibrillation progresses to persistent atrial fibrillation. On average, 15% of patients progress per year. And so again, delayed intervention or delayed therapy for paroxysmal atrial fibrillation allows people to progress to a disease that's much harder to treat and has a much higher risk. This idea was looked at in the ATTEST trial, which was published, I think, in 2022, which showed that early intervention for paroxysmal atrial fibrillation that was drug refractory, the patients who did not get intervention in the blue line had progression over the first 24 months to persistent atrial fibrillation. And so again, I think this is a sort of acknowledging that this disease is progressive, and if you don't intervene on it, it gets worse over time. Again, I think we need to talk about what rate control means for a modern atrial fibrillation patient, right? You don't need heart rates in the 60s and 70s, right? We're looking for an average daytime rate of less than 110 and an average nighttime rate of less than 90. 60% of those patients can get this with one drug. So again, this idea that you can't be on a beta blocker and a calcium channel blocker is not the case. Unless the patient has a device in their body, there's no evidence that digoxin has a chronic role in the management of atrial fibrillation. And so for patients who have drug refractory atrial fibrillation that's hard to rate control, those patients would benefit from intervention with AV node ablation and pacing. I think every patient who has atrial fibrillation has a symptomatic improvement with AV node ablation and pacing, and that's because biological systems don't like irregular rhythms. They don't like irregular anythings, right? And so the more regular you can create, the more regular rhythm you can create in the ventricle, the better cycling of calcium between the sarcoplasmic reticulum and the cytoplasm, and the more likely chance that the patient will have normal exercise tolerance. There's a cost to AV node ablation and pacing, and that cost is that you're consigning the atrium to atrial fibrillation for the rest of the patient's life. And so over time, that atrium is going to get bigger and bigger and bigger. And there are problems with that causes mitral regurgitation and creates an opportunity for increased risk of stroke as they age. The worst atrial myopathies are in the patients who've had AV node ablation and pacing for more than 20 years. And so it's just worth noting that there's a trade-off for this very beneficial therapy for the patients. And when we talk to the patients, we make sure that that's part of the conversation. Traditional RV pacing is gone the way of the dodo bird. We don't use traditional RV pacing hardly at all anymore. Physiologic pacing, and the difference between these, you can appreciate this QRS complex is wider in every lead than physiologic pacing of the left bundle branch. And so this lead is tunneled across the septum into the subendocardial tissue in the left ventricle and is engaging the left bundle just distal to the aortic valve. And so this complex looks like a right bundle branch block, and you'll see a lot of our patients have this morphology in the paced rhythm. Again, pulse field ablation. This is the biggest change with pulse field ablation. We're not using heat energy or cold energy, right? This is a non-thermal energy to cause permanent injury to the pulmonary veins and eliminate the trigger for atrial fibrillation. And the biggest benefit to the patient is in safety and in the speed of the procedure. The procedure can be done. The third case that we did on Monday, the left atrial dwell time of this catheter was 25 minutes. So again, I think that's as opposed to 4 hours when I started in 2005. So it's a big difference over the period of time, over just the 20 years of my career. So the pathophysiology of cardioembolic strokes, right? 90% of strokes that come from the heart come from the left atrial appendage. And the left atrial appendage is a important part of the mechanical systole in the left atrium. It provides an estimated two-thirds of the mechanical function of the left atrium. So it's not inconsequential. And it also is a pressure sensing organ in the left atrium. It allows us to measure the left atrial pressure for the neuroendocrine system and secrete the natriuretic peptides. The strokes that come from the left atrial appendage, 70% of them cause permanent disability or death. And if you have atrial fibrillation and a stroke, you have 2 times the risk of death compared to your age-matched control. And so left atrial myopathy, intraatrial conduction delay, increased left atrial volume index, all of those things are non-CHADS-VASc risks for atrial fibrillation-related stroke. And so when you're looking at your patient, those should be part of your conversation about whether the patient requires protection from cardioembolic stroke. It's worth noting that over the last 10 to 15 years, athletic pursuits in masters athletes have created a much higher rate of atrial fibrillation for those patients. And anecdotally, those patients have a higher risk of stroke compared to their non-athletic partners or non-athletic people in the population. And so, again, I think the reflex from a physician is, oh, you have atrial fibrillation, but you're really healthy. You don't need to be on a blood thinner. I don't think we have the data that supports that idea yet. And we've seen some of the more difficult cases have been patients who have had strokes as a consequence of athlete-induced atrial fibrillation or athletic endeavor-induced atrial fibrillation. Risk stratification for stroke, right? We still use the CHADS-VASc score. The CHADS-VASc score really is a way of looking at the whole patient. And it's not only, this doesn't only predict whether or not you're going to have a stroke. This predicts pretty well whether or not atrial fibrillation ablation is going to work. This predicts pretty well whether or not you're going to survive the stroke when you have the stroke, right? So the higher your CHADS-VASc score is, the worse you do in every domain related to atrial fibrillation. And that's not really a surprise. I think somebody in my training once said, if you want to make a good career in academic medicine, find the sick patients and prove that they do worse than the healthy patients. And I think that that's the case here. I have failed to do that in my academic career. So factor Xa inhibitors are the cornerstone now of atrial fibrillation stroke prevention. They live at the nexus of the amplification pathway and the tissue factor pathway for the coagulation system. And Eliquis, generic named apixaban, 5 milligrams twice a day for patients with normal renal function who are younger than 80 and have weigh more than 60 kilograms. It has a 12-hour half-life when it's been repeatedly dosed. The first dose is effective in 2 to 3 hours, and you need 2 of those 3 criteria I mentioned to do the reduced dose. I do see a lot of people on the 2.5 milligram dose, and it's just worth noting that that's not evidence-based unless they have the 2 of the 3 risk factors for bleeding that I just mentioned. Rivaroxaban, raised 20 milligrams at night. The original idea of dosing that medicine at night was the way that they got the indication for the single dose was that they gave it an excess dose than was required. And so the excess dose would be present in your system while you were sleeping. And then when you were climbing the ladder the next day, you wouldn't have as much blood thinner in. And so when you fell off the ladder the next day, you wouldn't have as big a head bleed. So again, I think Xarelto is an excellent medicine in that it's Q-day, and this, don't underestimate the difficulty patients have with twice-a-day medicines, right? The once-a-day medication and once-a-day indication is a non-trivial event for patients. It's worth noting people of Japanese descent have a prolonged metabolism of this drug, and so some care is needed. And if your GFR is reduced, you have accumulation of this drug pretty rapidly. Edoxaban represents a really unusual drug, and the only thing I'll say about it is the only drug where there's a precaution if your kidney function is too good. And so if your kidney function is too good, edoxaban is eliminated from your system too rapidly, and you end up with no protection from stroke. So it's worth noting that these drugs have a pleiotropic effect on coagulation. All three drugs affect platelet aggregation, right? And that's the reason that they've been used in vascular injury, in coronary artery disease and prevention of complications from peripheral vascular disease. And so this pleiotropic effect does increase the risk of bleeding related to these drugs and increases the risk of bleeding at surgery related to these drugs. And I think it's something to keep in mind when you're sending patients for surgery, that it's not just the factor Xa inhibitor inhibition that causes bleeding in these patients. It turns out, and I suppose this is unsurprising, that as you age, your risk of bleeding goes up, and it goes up pretty dramatically. These are major bleeding events over time, and this leads to frequent problems for people who take anticoagulation. And so that's, 5 years ago, when you're if you're an electrophysiologist, every conversation you had was about atrial fibrillation ablation. This year, every conversation you have as an electrophysiologist in clinic is about left atrial appendage closure and getting off blood thinners. And this is the reason for that, right, is that our aging population are having complications from the therapy of anticoagulation. Just worth noting, over the 10-year of the decade 2011 to 2020, the rate of anticoagulation for patients who are indicated for anticoagulation related to risk of stroke for atrial fibrillation went from half to almost 2/3. So that's pretty good. The use of warfarin was eliminated pretty much, and this depends on the market. And what's interesting about cost, Stephen, due respect, there was an analysis that looked at the effect of cost on prescriptions, and it turned out that groups of patients are getting different anticoagulation based on what their health system prefers and what their health insurance plans prefer. And we have good examples of that in our local market. And so that's largely driven by payers, and that hopefully that will end in the next year, in the next year and a half. The Inflation Reduction Act, one of the really important things for all of us to know about is that this list of drugs here, which I can't read from the side, represents about $50 billion in cost to the U.S. in Part D and Medicare. And for the first time ever this fall, the federal government will negotiate as a single payer with the pharmacy companies over the top 3 drugs. And then over the next couple of years, they'll pick 15 more drugs and negotiate for those. And so we'll see price reductions, hopefully, in these 15 drugs in the next, at the beginning of 2026. And that's going to be huge for our patients and huge for the society as a whole. Right now, it's fair to say a large number of our patients get their drugs from Canada directly, right? And that's something that just has to happen practically for them. Some new complexities to the guidelines that you may or may not be aware of. we do not consider gender a risk for stroke if the patient does not have other risk factors. And so if they don't, and age is counted as one of those risk factors. So if you're a 75-year-old woman, you don't have high blood pressure, diabetes, vascular disease, or prior stroke, you still have a CHA2DS2-VASc of 3. But if you're a 64-year-old woman, you have a CHA2DS2-VASc score of 0. And that's a little bit confusing. If you have patients who have end-stage renal disease who are maintained on hemodialysis, apixaban 5 milligrams twice a day is the preferred drug. And we can have some conversation about that if people want at the end. So atrial fibrillation that's complicating stent implant, triple therapy for 30 days, and then the DOAC or NOAC with the P2Y12 inhibitor for the remaining part of the year, or for as long as the interventionalist thinks is reasonable. So talking a little bit about left atrial appendage closure, right? This is the biggest conversation that we're having in our offices these days. It's indicated for people who are poor candidates or unable to tolerate anticoagulation for the long term. It's worth noting that all of the randomized data was left atrial appendage closure versus a patient who were taking an anticoagulant. And so in all those cases, the anticoagulation, most of those cases at this point, the anticoagulation was warfarin. And there are head-to-head trials right now with the DOACs in left atrial appendage closure. We'll have that data probably not very soon, probably in the 2 to 3 year time horizon. There are multiple devices coming. The most recent device is the Watchman Flex Pro. This is a device that fits inside the left atrial appendage and has hooks on the side that anchor it, and then a biological coating over the gore material on the surface of the device. In general, Watchman patients have had fewer strokes related to hemorrhage and fewer bleeding episodes with essentially the same risk of stroke as the patients on blood thinners. So we're a little bit short on time. This biological coating is a significant advance. It causes less platelet binding to the surface. You can see the red is platelet binding there. Less inflammation at the surface of the device, which causes coagulation. So again, the purple is inflammation there. And then it gives us a better chance of closing that device without leaks. Again, worth noting from the surgical literature that in the patients in a registry data, 3,800 patients who underwent left atrial appendage closure as part of their surgery, so 3,800 of 10,000, reduced the risk of stroke and reduced the total mortality for those patients. So I think we are on pretty good footing with left atrial appendage closure. And there, again, I think we're coming to a moment in electrophysiology where we'll look back and wonder whether blood thinners are the right thing to, or wherever the right thing to do here. The factor 11A inhibitors are the new frontier for anticoagulation for patients with atrial fibrillation and for other indications, including MI and peripheral vascular disease and non-embolic stroke. And the idea here is that you're trying to dissociate hemostasis from thrombosis. So hemostasis is the idea that if you disrupt a blood vessel, the wall of the blood vessel, that you'll get a clot at the surface that prevents bleeding from the blood vessel into the tissue around the blood vessel. And then thrombosis, right, is the problem that cardiologists spend their whole lives trying to prevent, which is this clot inside the blood vessel that is pathological, that causes heart attacks or strokes or DVTs and pulmonary emboli. And so the idea is that the factor 11A inhibitor acts only on the hemostasis part of the coagulation cascade and not on the thrombosis part of the coagulation cascade. And the initial trials, this seems to be, in fact, the case that this idea bears out in clinical medicine. It's not without problems, though. There are a bunch of different drugs coming. So there's monoclonal antibodies and there are silencing RNAs. The silencing RNAs, right, prevent the protein from being produced. the monoclonal antibodies bind to the protein and activate it. And so they work fundamentally differently, and it's just worth keeping that in mind because there's some conflicting data between the two drugs. So this monoclonal antibody, which I won't try to pronounce, it's a made-up word, so we can say it however we want. Right, it's tried in 2 different doses, and the primary endpoint was bleeding. Secondary endpoint was stroke and all-cause mortality. 1,278 patients followed for 2 years, average age 74, and it was stopped early because of excess benefit. So lower bleeding rates, equivalent stroke rate, and lower mortality. Right, this was presented at the HA in the fall. So this is kind of the latest, greatest situation, right? This drug is now in bigger clinical trials to try to figure out if this works in higher risk patients than these patients. Sort of in contrast, this drug, Syndexian, whatever you want to say that, is a silencing RNA that reduces the levels of factor 11 by 90%, and was compared to standard dose Eliquis, and this drug was stopped for safety reasons early, and there was an excess of stroke in the group that got the silencing RNA. And so again, I think the comparator arm was different, right? This drug was compared to rivaroxaban, and this drug was compared to apixaban. So again, that's an important difference, and the way these drugs work is different, and so we don't know what's going to happen with factor 11 inhibitors, but you're definitely going to hear more about them in the next couple of years. That's sort of the latest, greatest for drugs related to anticoagulation. I'll take questions.
Yeah, I think there's a new trial coming out. I think it's called the REACT trial with paroxysmal atrial fibrillation and then sort of paroxysmal anticoagulation following events. What are your thoughts on that?
For sure, this is a tempting idea, right? With the proliferation of devices that people are tracking their heart rhythms with. And there are for sure patients who are already doing this on their own, maybe with or without the help of doctors, depending on who's asking. In device data, the presence of atrial fibrillation doesn't correlate particularly well with the presence of a stroke. And I guess this makes sense because we know that the left atrial appendage thrombus can persist for some time after somebody has an atrial fibrillation event, right? So the answer is, I think it's going to be a little more complicated than I take my blood thinner when I have atrial fibrillation. Again, I think that it's really attractive, but I'm not sure that there's data to support that idea yet. The other piece to know, right, is that there's pretty good evidence that inflammation on the wall of the blood of the left atrium participates in the formation of a clot there, right? And so that inflammatory event is also hard to kind of figure out. So I think we'll have more luck with trying to predict stroke in people with more, understanding morphology and left atrial appendage transport and things like that. That's probably a more effective way to try to predict stroke. Even on blood thinners, right? There's not a zero risk of stroke, and even with no left atrial appendage, there's not a zero risk of stroke, right? These are all kind of the best prophylactic therapy we have at the moment. Behind you there.
No, great talk. I was going to ask you for the patients that have pacemakers or defibrillators, and you do a routine interrogation, you see, subclinical atrial fibrillation. And there's been some trials looking at this and what to do with those people, how much atrial fibrillation is enough to warrant anticoagulation. I don't know, what's your own practice and how do you interpret the clinical trial results, which from what I understand, are a little bit discrepant based on which trial you're looking at?
Yeah, so this is, again, the proliferation of what wearables has created this awareness that there are people who have subclinical, meaning that they have atrial fibrillation that is asymptomatic, and whether those people benefit as much from anticoagulation prevention as people who are symptomatic. Intellectually, I don't like that. Just that assertion, I don't understand it. So I struggle with that a little bit. There's data from the device world that after 4 minutes, your risk of stroke goes up, And so we've taken a really aggressive approach. We have, I think, Melissa and Yao can tell us for sure, but I think it's 4,500 people under remote monitoring, right? And so this comes up every single day, right? And so, and even the device companies are behind in this, right? The Medtronic, the lowest patient alert you can set, I think, is 30 minutes, right? So that's behind where we would normally anticoagulate somebody. So the answer is, I think at this moment, if you don't have a normal heart, we're assuming that data that says that 4 minutes is the threshold for anticoagulation. But I think it's not super clear, right, because of the loop data and the wearable data. And if Mel was here, he could tell us about what Joe Mendrola thinks about this. Any other questions?